No, it's just very bad luck at the angle I fell out on the course. Anyway, EOC customer. Right, good morning everyone. Welcome to this public board meeting, and first of all, the apologies for absence. Pat Baskerville and Debbie Aitayo are unavailable today. Declarations of interest. Any new declarations? Ian?
Right, I'd just like to declare that from May of this year I'm going to be moving to a new role, so I will be leaving the board, and the role I'm moving to is with the pharmaceutical industry. So I will be working for AstraZeneca, so I have to declare that as a not current interest but future interest, which needs to be transparent.
Thank you, Ian. Many congratulations, and I'm sure you will enjoy life as an academic researcher in Cambridge. It'll be very, very good for you, and for us, obviously, it means we will be finding a new clinical non-exec director. But well done, and thank you very much for all your work for the last, what, 4 years? Yep. 4 years, yes, thank you very much. Great. So, let's now get the feedback on the 15 Steps programme that some of our non-execs have been doing. My list here starts with phlebotomy, with Arlene and Rakesh. Yeah, I can add to it, because I was there yesterday, so.
As a patient?
As a patient, yeah.
So Arlene and I went to the phlebotomy department, which is at the side of Ferguson House. It's a standalone single-story building. When we went in there, and it's quite early, and it was full already, so it's clear that it's a really busy unit and a busy place. And waiting times were about 45 minutes, and people were streaming in as well. So it gets busy earlier on, and I think it gets quieter as the day wears on. We talked to one of the phlebotomists who'd been in post for about 7 months, and she sort of confirmed how busy it does get, especially in the morning. Although we asked her, and she had come from Tadworth Children's Hospital, and she was loving her job here. She wanted to be a phlebotomist, and she likes it being busy. Finds the interaction with the patients really sort of beneficial, and does have contact with her managers. Arlene and I asked how often she sees her direct line manager, and she sees him on a daily basis. So that was very good. But it's clear that unit is very, very busy. I don't know if there's anything more to add.
I mean, the only other thing I think I would say is we noted that, and in fact the phlebotomist said that they also man the front desk, so they don't have a separate person manning the front desk, so they take turns doing it, which means, you know, that they get interaction. But she was explaining that when you're out on the desk and you're sitting, seeing the people facing you, and people are there for an hour, it can be quite distressing for them. So I don't know, but I don't know if there's a plan for that to change, so we'll need to find out, because she didn't know. But I have to say as well that I sign letters to send out to staff who have had more than 3 FFT positive feedback comments in a month, and the largest numbers in December were from phlebotomy, saying that phlebotomy staff had been really kind, gentle, you know, really pleasant. So they are providing, even though the conditions aren't ideal, a really, really good service.
Yes, I can add to that, as I went there yesterday as a patient, and I did wait for about half an hour, but it didn't sort of seem like half an hour, because people get called, you know, every minute or so, so you can just see your number ticking down. I mean, it is what it is. It's a porter cabin, so it's not exactly glamorous, but the staff are very kind and very efficient and very effective. So I was I was quite impressed with it actually, because they do have to manage a very large number of people, some who have appointments from outside here and some who, like me, have just been sent there from some other part of the organisation. So it's quite it's quite an efficient operation considering how complicated it is to manage. Good. Next I've got outpatients Ferguson House. Daniel and Martin.
Sure. So I'll keep it fairly brief because I think it was pretty straightforward really. From a staff and a people point of view, extremely positive, very professional staff that we met, who are also very engaged in the work we're doing on values. I'd say that in contrast to that, on the other hand, most of the issues were around the building and the space. So we know these things, but it really certainly brought it home to me that because part of the building has got a flat roof, there is water coming in every time it rains, which means that there's a constant waste of money in having to replace the ceiling tiles. There's a sort of contraption into a bucket for the water to come through next to all the high-tech medical equipment and so on. The other thing that I learned more about was that they've actually had a great deal of success, this is in layman's terms, but in rheumatoid arthritis, with reducing the amount of time that patients have to spend in hospital and the amount of time that patients are coming, the numbers coming to hospital, because the nurses have been able to train patients to self-administer drugs and then to then work with the GPs in the community, which has taken some of the pressure off. But say overall very impressive. So.
Sounds good. Thank you. Trevor and Elizabeth, Elizabeth.
Yes, well, if we have heard about the challenges of the infrastructure in A&E and phlebotomy, I would say that the I unit is at the other end of the scale. It is the way you would like it to look. It's a fantastic modern unit which was opened 4 years ago when we relocated everybody over from Sutton Hospital. It is a very good environment for patients, and the feedback we received from staff was that they also enjoy working in that environment. And even though it's 4 years old, it has worn very, very well. And so the first thing you notice is it is clean, tidy, and pleasant to be there. We spoke to some of the patients who told us that they had had excellent care on many visits to the I unit and were very, very supportive. We spoke to one staff nurse in particular who had come back into the profession having had a career break. And so last year she joined, and she was absolutely so positive about the induction program that she had been put on and all the support which the trust had given her to meet her requirements, because she has a son who has particular needs and that kind of thing. Negatives. The patient transport system doesn't always work the way they want it to. Lifts are a problem. What else would you add to that, Trevor? But it was a wholly positive experience going there, and such a pleasure.
And I think you're right. I mean, I think for me what was quite good is that after 4 years they've still looked after, maintained the area, and it looks uncluttered and clean, which was good. I think, yeah, regarding the patient transport, that was more around some of the weights that they're having and the access to the transport lounge, which is currently in G block over there. So it's quite away from the hospital. G Block has one lift, and that has broken down quite regularly, as we're aware of our lift challenges. We are moving our patient transport into A Block in the next sort of 4 months, so that will hopefully improve. But lifts was an issue. I think for us as well, you know, it's a very friendly environment. There's probably just a couple of minor things that we need to pick up on around their locking of the clean utility room, and there's we checked temperatures. They were fine. They were doing their fridge temperature checks, but there's probably a few days missed around on the defib as well that we need to just make sure they're on top of. But overall, very positive experience.
How busy was it when you went? Not a bit early, was it?
Okay, they were running a very busy paediatric clinic. They were running a casualty walk-in service, and there were about half a dozen people waiting for that. And they had 2 clinics running. They didn't seem to have anybody working on the laser or that section, did they?
No, I think that the plan procedure side was not running today. So, yeah.
Peter and Ian went to C5.
Right, so C5 is a medical escalation ward, so opened up for excess capacity, and a consequence of that is that the degree of temporariness to the staffing involved there. So we spoke to the nurse in charge of the ward, who was there working on bank, and all of the staff there are banking agency. So the main issue that they raised with running the ward was the slightly transient nature of the teams concerned. The medical team seemed to have a bit more stability, but again was, of the 3 junior doctors there, one was long-term Epsom St Helier, and there was one bank doctor and another one who was from a locum agency just there for the day. Air of calm efficiency, which I think is the general atmosphere of the wards here. Physical space is always an issue, so when we came onto the ward, narrow corridors with equipment and things there that just nowhere else to put them, so inevitable, but made it feel a bit cluttered. Outside the ward there are 2 lifts, and Peter commented that a marker of the state of lifts in the organisation, there was a sign on one of the lifts saying this lift is operational, suggesting that the default assumption is that the lift might not be operational. So, and one of the 2 lifts there was out of order, so of course it's down to potential single point of failure there. Plenty of sinks on the ward for hand washing, but you would have to climb over either a patient or a bedside locker to get to them. And again, it's this physical space constraint there that it's hard to see a way around that with fitting the number of patients in that's required. There were empty beds, which for a place taking acute patients for patient flow looked fantastic. Certainly the ward I work on, to see an empty bed is incredibly rare. So that's something that cause for optimism, perhaps. In terms of speaking to patients, so most of the patients seemed confident in the care they were getting. Food was fine. The ward was generally quiet and calm, but one patient had a disturbed night's sleep with noisy patients. That's, again, that sort of area. I think there's a degree of inevitability on it. Peter has a patient story which I will leave to him to pick up. Spoke to the consultant who'd come to do his ward round, and his main issue was that about 50% of the patients on the ward were medically fit for discharge, but because of the difficulties in getting patients back out into the community, was keeping patients in St Helier. I popped into the immunology day unit, which was attached to the ward, and one of the concerns has been supply of intravenous immunoglobulin, and they said that for their patients they'd managed to get the drug for all of the patients that needed it. And in fact, it wasn't really on their radar as a major concern, which suggests that the system for allocating intravenous immunoglobulin to appropriate patients has been working. And I'll pass on to Peter.
So one of the patients I spoke to was very articulate and was very positive about the kind of the meeting his day-to-day care needs. His one concern, he had complex needs, so both medical and surgical needs, and my takeaway from his concern was that he didn't really understand all the different bits that were happening to him and wasn't getting a clear sense of what's his whole care plan to get him home, as opposed to what are we doing to him next. So he was, the way he described it is that the team was fixated on he's got to finish his course of IV antibiotics before whatever the next steps can be, but he didn't really have a sense of what's all the things that's got to happen before he's actually going to be ready to go home. So I fed back to the nurse in charge that actually someone needs to sit down with him and actually communicate with him what we're doing for him and with him, as opposed to him.
Yes, thank you. That's a good point. That is very good. Aruna and James, you went to A3, B3.
So we went to A3, which is our hip fracture unit. The impression when you walk onto the ward is that it's an extremely cluttered environment. There were delivery crates, there were food trolleys in the corridor. We had a chat with the kitchen staff, and the kitchen is certainly quite small, but you know, they felt they were doing a good job, and it was hard to see that there was obvious ways that they could store equipment differently. The ward board was up to date, the staffing was complete, and they were fully staffed, so that was good to see, and it was clear that the nurses took ownership of the staffing and keeping things up to date. And I think we did speak to the consultant who was doing a ward round, and there's a real sense of team on that ward, from the therapists to the nurses and the doctors and the cleaning staff working together as a single team, and a real sense in pride in the work that they do. I noticed that Sam, our Chief Registrar, and Sandy, our Guardian, are there, and they're going to be giving a talk about exception reports, and we have more exception reports from the junior doctors on the hip fracture unit than in many other areas at the moment. And the junior doctors reported back to us that they don't have a fixed number of beds. Their work increases as the number of people falling over and breaking their hip increases. And this is a particularly busy period. They did have some suggestions about how their workload might be mitigated. But the one thing that came through loud and clear was that they felt that they were delivering excellent care. They felt that they were in a very supported team. But they did also recognise that they were working very hard. The ward environment definitely could do with improvement. It is very cluttered, and it doesn't feel coordinated. And I think that was actually the biggest gripe among the team that were working there. And they were about to start their morning multidisciplinary team meeting, and it's very, very crowded around the nurse's desk. But they just roll their sleeves up and get on with it. It felt to me as a very positive ward to be on and to visit. And the patient I spoke to spoke very highly of the care that she was receiving.
Yeah, I mean, I'll echo everything that James said there. I think just a couple of things to add to that. I think, again, speaking to the consultant on the ward, they were obvious. Estates was right at the top of the list in terms of kind of making the ward look a little bit more professional, especially the curtains, just maybe even changing the curtains around there. You know, around the beds would be helpful. The other thing that she did speak about, James, was the occupational therapy. So we have 7-day physiotherapy, but only 5-day occupational therapy, which impacts on the length of stay. They have just hired a discharge nurse to make things more coordinated in terms of reducing their length of stay. But I think she felt very strongly that having 7-day occupational therapy to get patients up and about and out quickly would be helpful. I also would add that the nursing staff seemed to know where to go in terms of escalation. They said there was an 8:30 meeting every morning where they could escalate their concerns. They said there is a change in terms of the number of nurses they need and the staffing of the ward, and the wards are better staffed now. They also said that the head of nursing was very supportive and very accessible, which I thought was a real positive step. So, I mean, again, echoing a little bit about what James is saying there for the doctors and the nurses, I mean, this could be an exemplar for your voice, your values. I think, seeing that strong leadership coming from the clinical end has actually permeated, I think, through the whole team. They feel very much as a team unit, very energized, even though we're getting the largest number of exceptions coming out of the ward from a junior doctor perspective.
Thank you, Irene. Trevor, are there any plans to improve A3? Is it on the list?
I think a lot of our wards are on the list. I think our challenge is the list that we want to do in the capital resources and balance things like the lift investment, critical infrastructure. I don't think it's on the top of our priorities for next year, but I think there's certain things that we can look at, such as curtain replacements and some work we'll certainly go and do. What can we do within our existing teams' resources?
Just to say, in terms of the curtains, there is some work that we're doing from a nursing perspective around looking at the areas that we can swap to the disposable curtains, which initially, because we can use the same tracks that are there, so that is work that we're looking at now.
Yeah, because we've got.
Yeah.
And I think we have a challenge with those old style Nightingale walls that just do not have the storage space to things. The kitchens need to be double the size to put the trolleys into them. If you knock that out, you take out another room. So we are significantly challenged around how we declutter those corridors. I think we're acutely aware that that's an issue, and we are trying to constantly look at that. But I think it's like what we've done on some of the other walls, where it needs the conversion and changing. But equally, you then take a ward that's 17 beds down to 13 beds, and it's managing our demand on beds as well. So it's capital investment, and actually even then the building isn't really the right design and shape for us to deliver the healthcare that we want to.
Okay, thanks. Finally, surgical assistant, Chris.
Yes. Thank you. So this was, I found it interesting because I've never been on this ward before. It's a new ward in the hospital, new concept, which I guess mirrors what's been happening with on the medical side for a while. And walking in, it was fairly quiet when we walked in. The place is new, it's painted, it's not scuffed, the flooring is nice and smooth, and everything that you would wish, but then of course it is new. And hand hygiene stuff was in place, sinks and everything, so that was good. We started off with a discussion with the nurse consultant on the ward, Beatrice, who was very helpful and welcoming. She explained that they have their core staffing is of 3 staff, an ANP, a staff nurse, and a band 4 healthcare assistant. I hope I've got those right as far as Arlene's concerned. And we talked with the ANP and with the band 4. The issues that came up, I think, were issues of a new unit, whereby I think there's still some uncertainty how best to use it. They felt that sometimes they were having patients come there who were just being moved out of A&E, and they were sort of they'd waited in A&E, they then moved up to the surgical unit, and then they sort of waited again, rather than having a plan that was up and running when they got there. There was also some issues about accepting patients from Epsom and not necessarily having all the record that came with them. There was a case recently where the patient was sent over to turn up to come in the next day, and there were no actual records, so that delayed things for the patient, obviously. Having said that, they felt that the ward worked well, that it was doing what it was supposed to do. They also see quite a number, particularly at the weekend, they do quite a lot of post-op dressings on people who've been discharged home, and we had a conversation as to whether this was something that could be done better in the community. Now, obviously, some dressings probably do need to come back to be seen by the hospital surgeon, but others, it maybe there's a way of getting some of them done in the community and making sure it doesn't become a place where people go to for their dressings. But the nurses weren't complaining about that. They were just commenting that this was what they were finding. And also with the nature of things, you know, sometimes patients would phone up their GP nurse, ask for an appointment, and be told that there wasn't one on the appropriate day. And so they felt they were acting as a as a safety net on that. And that's an issue which, you know, bigger issue which, you know, we may need to think about because we're trying to make more care in the community. I talked with the junior, one of the excuse me, one of the structural staffing structure is that there's an F1 surgical person there who works 9 to 5, 5 days a week. I had a chat with her. She enjoyed the experience of working there. She said she got a lot more patient contact than she did on the rest of her rotation. She had a comment that she thought the IT was a bit clunky and that clinical documents keeps dropping out, or when you close one page it kicks you out and you have to reopen it and so on. She felt that she had good access to advice from her registrar, particularly in the afternoons. There's also talking with them, there were links to the surgical ward, Mary Moore ward, and it seems that there's a little bit of symbiosis between the two, with Mary Moore being a place where they can. Well, there were two elements to it. One was if Mary Moore got very busy and there were staff shortages, there was a bit of a feeling that maybe if the surgical ambulatory care unit wasn't too busy, maybe staff would be borrowed from there to go to Mary Moore, and you know, maybe that's what needs to happen in case of need. But also it felt that it was a supportive thing because this was a bigger team, not just the surgical ambulatory care unit. They had a larger place that they belonged to, which is a good thing. I chatted with a patient who was seen yesterday in A&E by the surgeons, didn't feel he needed admitting, but needed further investigation, so he was booked to go to that unit and had a CT scan booked for later today and would then be reassessed. So, you know, I guess that's how it, you know, that's what it's there for, you know. So this chap, who was, as far as I could see and as far as he said, was perfectly fit to go home overnight, but still he was getting his treatment and assessment in a timely fashion without having to spend a night in bed at St Helier. He said he'd been a regular customer here and had nothing but excellent treatment all his numerous visits over the years, so he was very complimentary. I think that, and we went through the checklist of medication storage and so on, and that was all okay. Thurza, do you want to add anything?
Good, thanks very much, Chris. It's good to know that these new units are.
All right, I'll just ask.
Yeah, Richard.
Pose a question on that. It's really for Trevor. So, with all the enormous amounts of investment we've made into the infrastructure and the fabric of the hospital, I'm interested to just understand when we go back and review 6 months, 12 months after the work has been completed, how it is standing up to the day-to-day wear and tear, and whether there are any particular lessons, observations that emerge from that.
So we do post-project valuations on a lot of our capital investments. I think one of the first things you may have noticed that on Mary Moore elements, so we've got the surgical ambulatory care unit and Mary Moore. There's two sections of Mary Moore. The new section is what we'd say is health building note compliance. So the space is much larger. It's a modern standard space, and it's very spacious. So, and then if you go to the other section of Mary Moore, it's the old style. It's it's better than it has been, but it's still not necessarily the space that we'd require. So the first things that we would pick up on is a constant issue, and probably a little bit that I picked up with Elizabeth in the eye unit, is walls. We always constantly have issues around protecting the walls, so chairs up against the walls will scrape at the bins. Sometimes we find the bins will stain the flooring, etc. So I think generally we look at the standards that we're delivering to in terms of the finishes, the quality of those finishes are standing up well and looking good. I think what we do find is that when we work with the ward staff, the clinicians and nurses, and design something with them, there's a lot of time we find that what we've delivered them isn't actually works well for them, and you do find that there's times that, you know, what this used to be a clinic room is now being converted into a consulting room because that's how they've changed, that they actually didn't realise how it works. And I think for us, one of the things that we find is that we work with nursing clinicians and look at plans, but actually it's harder for them to visualise what is the end product. And one of the things that on a larger project we're looking at is actually 3D modelling, so actually people can walk through and actually understand how that would be visualised. So I think generally what we're looking at is the standard finish that we're finishing are good. We do find, I mean, and our unit again is that we haven't sorted out above, and there's still like constant water leaks coming through certain parts of the unit, etc. So it's generally the quality that we're delivering to is maintained, but there's always things that I think we need to go back, additional protection and addressing some bits and pieces. Does that answer?
Thank you. Thanks, Richard. Right. Thank you very much. I think, once again, quite a lot of reassurance, a number of issues, as is usually the case, but yes, very useful. Good. Let's quickly then do the minutes of the last meeting. I'm not proposing to go through them. I'm really just going to ask if people have got any comments on them.
We just have the 15 steps summary of October.
Yes. Oh, sorry. That's not on my agenda. But do you want to do that?
Well, no, just to say that we started collecting and collating the feedback from the 15 steps in October last year, just so that we can provide some assurance that the feedback is used to make the changes that we've said are needed. And so this document, which is included in the pack, just gives a summary of the things that we found and what were done about them in a couple of main themes. Environment, we know, always comes up, as does staffing, and we always seek to get patient feedback. So it's really just to say that we're using this 15 steps process to give us information that we need to make changes, and we're demonstrating that we do make those changes. And I suppose for me it's about giving assurance as well that while we have these just before board, these are not the only opportunities that we use to visit areas. Each one of us will do, maybe not a formal 15 steps, but we'll go to areas as part of what we do every day. But this paper just gives a summary of it.
I could just comment that we did make it explicit that C5 is where I think Richard and Trevor had been some months ago, and it wasn't really fit for purpose after as an escalation area. As you heard at the last board, lots of interventions have been put in place, and I think Richard, Ian and I would agree that actually now this is it's fit for purpose. You know, the remediations were put in place. Clearly, it's still not perfect because that's the constraints of the layout, as opposed to it's not clean, you know, with the right supplies in place. So this works as a tool, not just as Arlene says, that's the only measure of finding things that don't work or finding opportunities for praise, but you know, we've clearly taken action.
Yeah, I mean, I think that you only have to look at places like the ophthalmology department to realise that it is possible to create modern, high-quality facilities up to a point. You know, if you look outside, you can see B and C blocks that really quite splendid now. Now they've been refurbished, and the scaffolding's down, and the windows are secure, and the roof is secure, and it makes it much better. Having said that, there are all the limitations of the physical construction of this building, which mean that it can never ever be, you know, what it would like to be, or what we would like it to be in terms of modern healthcare standards. So I think the answer is we've got to continue to do the best that we can within the fabric that we have. Right, good. Yes, minutes. Does any board member have any comments on the minutes? 'Cause I'm trying to catch up a little bit now. Are we all right with the minutes? Good. In that case, I'll go on to the chairman's update, and I really just want to talk about, as usual, some of the strategic things going on with the NHS. I was at a meeting the other day with the other chairs of London trusts, of all the London trusts. Sandra will take questions at the end. We were meeting with Dido Harding, who is the chair of NHS Improvement, the new chair, and really to get feedback on the new, which you've probably seen all about the 10-year long-term plan for the NHS. And I suppose I'd categorise the priorities of the NHS in London as sort of 3 C's, really. So it's capital, and the answer is there isn't enough. It's quite clear there is not enough to do everything that everyone wants. So there's going to be a competition between various parts of London to get capital, and that's a problem because there isn't enough. But it was also clear that there is a view in the Treasury that the NHS has done much better than other parts of the public sector, such as local government, such as police, such as criminal justice system, such as social care, and therefore the NHS has got to really justify every single pound it gets in terms of capital. So capital will be an issue. The next, and I think it builds a bit on what Chris was saying earlier, is about community. There is a clear drive to push as much activity away from acute hospitals, so the acute hospitals focus entirely on really acutely ill people, and to put as much of, if you like, the day-to-day business of healthcare into the community. So I would, in a southwest London context or in a local context, those of you who know the Nelson medical practice, the old Nelson Hospital, which has got, as well as 2 combined GP surgeries, previously independent, now put together. It also has, I think, 2 X-ray machines, it's got ultrasound machines, it's got phlebotomy, it's got all of those services all in the community, in a quite large building, but not an acute hospital, although it used to have, I think it used to have an outpatients department back in the day.
It used to do maternity.
It did used to do maternity, didn't it? But so it's now, and that sort of Nelson model is what they want to see in London, all over London. Now, obviously, that goes back to the first capital, because you can't build those for no money. So the aspirations are there, but we will see about the delivery. The final C that they talk about a lot is culture. The NHS is a huge organisation, it's the biggest employer in Europe, and feedback from all of the surveys, whether it's the annual staff survey or individual surveys, it's not as happy a place to work for most of its employees as it could be, or as it should be. And people are very conscious of that. 70% of the money that is spent annually on the NHS is on people, it's on our staff. And they've got to improve the culture. And that's why something like Your Voice, Your Values, which we're doing here, is viewed as very important as part of the overall culture change, which is essential for an industry which is essentially a people industry, which employs so many hundreds of thousands of people. And if you can't get the culture right, you can't get the whole service right. So that's, if you like, the message of the 10-year plan. I'm trying to encapsulate it. But I suppose the attitude from quite a number of fairly hard-bitten London chairs was, well, that's great. We all agree with that. Now, how are you going to get it delivered? And that, I think, is the big challenge, which we'll see how that unfolds over the next few years. So that's my message. Daniel, yours.
I hadn't realised how long it was until just working out how do you summarise this quickly. I think it just reflects just how much we're trying to do all at the same time in Epsom and Helier. So I think I'll just, in a high-level summary, say we had our latest CQC report back that upgrades 2 of the services at Epsom and makes Epsom go to good for well led. So Epsom now looks as green as the St Helier one does. We're beginning full scale to mobilise all of the community contracts that we are taking on from April. And since I wrote this, we also can announce that Sutton Health and Care won the contract to provide sexual health services for the London Borough of Sutton in partnership with the GPs in Sutton and the Mental Health Trust. And that also has a start date of April, so we now have 4 contracts to mobilise from April. Lots and lots of stuff on estates, both really good things of departments opening and people opening new things. And I suppose one should just also comment on the outpatient area at Epsom, where we created something amazing and then discovered the brand new lift that we had installed just was not fit for purpose, so we've had to move out again, and that has caused a lot of chaos for lots of people, but the staff have been brilliant in creating a temporary outpatient department quickly. And then lastly, lots of awards for staff who've done amazing things in the last few months. So big thank you to them. And I should also just comment on A&E. So yesterday you'll have seen that there was the worst performance England has ever had for A&E in January. And we were slightly worse this January than last January, but we were still 31st in the country and 3rd in London for A&E performance. So we haven't actually changed our position at all. It was spectacularly difficult in January, and February hasn't started much better for the NHS either. But that's a bit of I should have finished on a high point as opposed to a high point would be, would you all like to come and join us on walking between Epsom and St Helier on April the 7th to help us raise money? We're trying to get as many clinical areas to join in the walk as possible, where they will all raise money for their own area, and then the trust will double anything that they raise, so that we can have a whole heap of little improvement initiatives right across the organisation. And it's to celebrate 20 years of Epsom and St Helier existing. There we go.
Thank you, Daniel. Daniel didn't mention that he is now the longest serving ever chief executive of Epsom St Helier, which is very good. The annual turnover rate of chief execs in the NHS is, I think, the average length of stay of chief execs is less than 2 years. So for Daniel to have been here for 4 is a great achievement for him, for us, and we're all very pleased about that. Can I ask a question, though, about lifts? We've had the word lift turns up more and more than it used to. I mean, 10 years ago or 5 years ago, we never heard the word lift. Why? Is there an issue? I mean, there obviously is an issue. There obviously is an issue, but what is the issue about the lifts? Why are they all breaking down now? And is there anything that we can do sort of globally, as it were, or over our whole lift estate, if that's a phrase, to try and improve matters?
Do you know how many lifts there are?
No. Tell me.
38. 19 on each side.
Yeah. Okay.
But they're passenger or bed lifts. There's some other good lifts as well in that. So there's no one single answer is the problem of here. So there's a combination. There's a combination of that we have lifts. And we know that we're quite vulnerable in terms of our lifts, that we've got some buildings, and we haven't really got modern facilities for bed lifts, the first thing. So when a lift does go down, it has a major impact. There's a combination of, in effect, just a lack of a annual investment programme in our lifts over the years. We haven't effectively put the investment into those lifts. That combined with we've had some poor performance around the maintenance of those lifts from our contractors. There's probably been the 2 major contributions in there. Predominantly lift issues have been on the St Helier site, and certainly in the main building. It seems to be one issue after another, and the problem with those issues is that there have been major failures. So we've had gearboxes totally fail and total replacements or total repairs, which are taking us 6 to 8 weeks to actually have that turned around. The trust has put the capital in, and we are this financial year looking at around £700,000 being put into lift upgrades and repairs, and we're looking at a further £750,000 next year to try and improve that. But it has been a catalyst of just one after love on the St Helier site. And top with that, when we did the B and C block works, we had the contractors didn't effectively cover the roofing, and that caused a fire, and that lift was a total replacement, and that was our Fiesta bed lift. I am pleased to say that Fiesta bed lift is operational as of yesterday, and it seems to be working, so that's good. And I think we are getting to a stage where we are now beginning to get more back on, and I'm confident by the end of March we'll have all of our lifts fully operational and those major repairs are being undertaken. We have employed some specialist consultants to help us in a couple of things, helping us into target where we actually need to put our investment in the priorities, rather than us just guessing. We actually get some of that work done and effectively target our upgrades. But also we're going to be changing the way we undertake our maintenance contracts. So rather than it be undertake a monthly service and then just come out and repair, we're turning that round to actually, here's a capital investment, but at the same time you will maintain at a cost these lifts and you are responsible for breakdowns. So unless it's a catastrophic failure, you will be held responsible and will have to fund yourself for those repairs. So it will cost us probably double the amount of money that we're currently paying on our revenue contracts, but it will mean that actually they are responsible for making sure they do the maintenance, and they'll have an interest in actually putting the right investment in the right place to ensure that our lifts are operational, and there'll be some performance indicators around the uptime of our lifts.
I thought there was also a problem in getting spare parts because of the age of them, is that right?
So I think for some of our lifts there's been challenges around having parts from Germany, USA and some other countries, and there's a conversation that we've done on some of those areas about let's just order those parts now and keep them in stock. The problem is that there's so many different parts, and you could spend hundreds of thousands and it'll still be a different part that's gone. That is part of some of the issue that we've had around the parts, and not so much the that way they're broken down. It's been the delay in getting those parts here has not helped us, but it's not the whole problem.
Yeah, I mean, clearly the maintenance, I think the maintenance contracts are an issue. I mean, presumably our experience is, as you say, now leading us to change the way that we do our maintenance contracting. Is that right?
I think what we've got to do is, it's very much being, we give you a price every month to service our lifts, and then when they break down we give you more money. What we want to turn it around is that you've got to provide us with a performance lift at a certain percentage of operational time, and we'll pay more for them to provide that performance responsibility, but then it'll mean that they will put more time and effort into ensuring the maintenance is undertaken to actually prevent them from spending more money on repairs.
Thank you. Anyone else? In that case, let's move on to the integrated performance report, and we'll start with Ruth. Thanks, Ruth.
Should we try and do it briefly?
Yeah, we'll do it as quickly as we can.
Okay, thank you, Lauren. So just to pick up some key points from the performance report. First page, looking at mortality. I think what is important to highlight is that whilst our HSMR year to date remains in range, in the month of September we had more deaths than we would have anticipated. We have done a deep dive into those deaths, and actually the positive feature coming through from that is, firstly, most of those deep dives had already taken place through the mortality review process, and looking at the two categories where there were excess deaths in terms of chronic obstructive pulmonary disease and acute renal failure, the review to date has not demonstrated any clinical care or service concerns, which I think is important. It's also important to note that although this data relates to September, in the months since September, the number of deaths per month we know has fallen back to our normal level. So we think that this was a blip in September, and are confident both our review processes are producing the required dividends, and also that our run rate has now returned to normal. So that was the major thing I wanted to highlight on the mortality page. Moving on, to highlight that the performance around stroke has improved. Clearly winter pressures were still evident, or very evident in November, which led to not all patients being able to spend the majority of their time on the stroke unit, but the position had improved and continues to improve in month. TIA position is strong in the month of November. And I look to James, who I'm sure will want to reference the V2E performance, which in the month reported here had actually exceeded the 95% target.
This has been a challenging area that we've struggled to deliver the 95% target. I don't think we have fully embedded the process as we would like yet, and there's more work to do. But I think it's good to see that month on month the performance is better than last year, and most of the improvement has happened in the surgical specialties, but we've still got ongoing work to embed this.
Okay. Thank you, James. In terms of dementia, Ali may wish to talk about this later, but the dementia strategy has been refreshed, and there is a renewed emphasis on the care of our patients with dementia, a consequence of which I think is early shoots in terms of improved screening rates that we're starting to see. But we have a whole-scale dementia strategy now, which we will be sharing with the board at a future date. In terms of the reducing avoidable harm, I would just want to emphasise a strong position with duty of candour, and to reiterate a previous message that we are reviewing our root cause analysis processes, and actually during the month of January, in order to ensure that we complete our investigations in a more timely way, we ran a pilot where every morning there was a whole hospital call, where any incidents that had happened in the preceding 24 hours were picked up, managed, and that allowed some of those incidents to be investigated and closed within that working day, and it was a very successful pilot. We are looking to seek to roll out that approach more widely, really from April onwards, and we'll report more formally to the board on that proposal at a later date. I'll hand over to Arlene.
So safe staffing, we continue to monitor our staffing levels using the model hospital. And there is a lot of work that is going on behind the scenes in ensuring that our processes are correct and that we use the IT systems effectively that are available to us. So there's more use of safe care on a daily basis. We have, and I think somebody mentioned earlier, staffing meetings twice a day, at minimum twice a day, to look at how we allocate staff across the sites. And we have a third one if it's required, if we feel that it is a bit or not as good as it could be. So that will continue. The red flag that we monitor, which is about one nurse on a ward, we ensure that we follow that up. And now we know about it in a more timely manner, we're able to check whether it is affecting safety of patients. And the one shift that is here is really where we had 6 patients on the ward, so we didn't need 2 nurses. But we will continue to include them in reporting. Healthcare-associated infections, we remain just with the one MRSA bacteremia for the year, and as long as that continues, we will just have the one. For C. diff, we have had a total of 25 cases over the year, and that is within our internal trajectory, and everybody's really working to ensure that we stay that way. We did have a confirmed norovirus outbreak for 11 days on one ward. The infection control team worked really, really hard with the nursing staff on the wards, and everybody really pulled together to contain this outbreak. We've started a process where we are going to do a root cause analysis kind of investigation around outbreaks so that we can get even more learning to going forward. Maternity care, it continues to be green in most of the areas. although cesarean sections and cesarean sections have come down. Postpartum hemorrhage again is another area that we are continuing to look at quite closely and monitor going forward. Birth centre births have gone back up, and that's due to the lifts, the work on the lifts being complete, and we're able to use that to use the birth centre more effectively and regularly.
Thank you. Yes, Lisa, from patient experience.
Thank you. In terms of the friends and family test, one thing to highlight is the friends and family test specifically for A&E. It continues to be very strong, not just in terms of the numbers of people completing it, but in terms of the recommender score. We were with some colleagues yesterday from across Southwest, from across London, and they were saying our score in comparison to others across London is maintaining to be very strong. Particularly of interest on that A&E score is the not recommender score is significantly lower now and is maintaining that position and has done for several months. So I think that's important to note. In terms of the patient advice and liaison service, it continues to be busy. December, the number of inquiries and queries was slightly down. However, January is a bumper month for us, and we've hit over 600, and that's the first time ever we've hit over 600. But I would like to highlight, particularly for Trevor, because I know him and his team have worked really hard on this, the number of concerns relating to the ambulance service, so that's the internal transport service, has significantly gone down. So all of the communication and work that's been done on that, we are starting to see the fruits of that, because I'm not seeing them coming through PALS. In terms of complaints, we're still holding a strong performance in terms of complaints responded to in the agreed timescale, and we are not seeing a high level of reopens. So again, it shows that the complaint responses that we're giving are strong and are what the person raising the concerns wanted. We are seeing an increase in the number of meetings as well, which is a good thing because it enables us to answer everything that all the concerns that people raise.
Thanks, Lisa. Can I ask, when there is a meeting about a complaint, that's presumably with either the patient or the patient's family, who tends to attend those on behalf of the trust? Is it the actual team that's done the caring, or is it managers, or how does it work?
It's normally some of the senior team attend, but also we do, if it is appropriate and where it is appropriate, the person delivering that care would attend too, along with a senior complaints person who is there to support both the hospital staff but also the complainant too.
And what sort of learnings do we tend to take out? I know it's difficult to generalise, but are there any themes that come out of those meetings?
Yes, and we capture those, and they are part of the learning that we put in place. A lot of it, to be honest, is around communication, and a lot of it is around misunderstandings and people not understanding the care or the treatment they were on. So there's a huge amount of learning around that for staff, and some of it is around the time scales. So it really is that the meetings are really beneficial both for the people who have raised the concerns but also for the staff. So we try and push that as much as we can in terms of learning.
Thank you. Good.
Sorry, Lawrence.
Sorry, Chris.
Sorry, if I might.
Yeah.
Just thinking about the surgical ambulatory care unit, which is new. I saw the Friends and Family test post box there, if that's the right word for it. Do you, when you've got a new unit that's open, do you sort of focus at all on that in terms of patient feedback?
Yes, because we for every area we capture the feedback, so and that is made available to the staff. So that is both in terms of complaints, PALs, but also in terms of the FFT, and we do that in real time. So it's not just the scores, if you like, how many people filled it in. It's actually what people are saying, and we capture that. And every area has access to that data. We monitor that so that if we see an issue arise, which we did originally going back, if you remember, with A&E, we worked with Health Watch colleagues to come in and to do a deep dive into what was going on and put in place some changes based on that. So the short answer is yes.
Thank you. Because any new unit is the place where you're likely to have teething troubles, isn't it?
Yes.
I mean, that's natural, really.
Thank you very much. Thanks, Lisa. Who's going to do cancer? Because Dan. Yeah, do you want to do it?
So cancer standards all delivered for the month of October. Elective care, we've gone up to Christmas, and you can see that our RTT performance is better in December than it was at the start of the year. There are less working days in December, so your waiting list always goes up a bit because you have less days to see people in. But broadly, the RTT stuff is going in the right direction, and A&E we've already spoken about.
Okay, good. So we'll move right on to workforce.
So I'll cover this in Debbie's absence. So I'll just preface the comments by saying that we went through at some detail at the People and OD Committee at the end of January to review the key metrics, including a thorough conversation about how we address our staffing challenges, particularly around workforce numbers on the ground. So the one metric in here which we're starting to focus on more closely, particularly with nursing staffing, is the total fill rate. So we've on many wards, there may be staff absent because they might be off sick, as well as the gaps in the establishment, and then we use bank and agency staff, but on a number of occasions, as the data shows, that actually we're not achieving the fill rate that we've said that we need on a reliable and robust basis. So getting in underneath that was part of the conversation that was about both a dialogue around what do we need to do to make Epsom and Helier an attractive place to both stay and as well as join, and there's further work that we need to do around both of those components. Next time we'll be able to review where we are with our staff survey as another insight into that, and that all leads into the work we are doing around sort of staff engagement and behaviours and values to ensure that people do feel that this is a great place to work and to stay and to attract new members of staff. So the data overall basically reflects a pretty stable picture, which doesn't give the true sense of the amount of work to stand still, as it were, in terms of the metrics. So that's the summary of both those pages.
Are there any points on the workforce? Okay, let's move on. Back to Lisa, the comments.
Just one thing to note, it actually isn't on there. You remember we launched our own podcast. We think it's the first in the NHS, and we've done another 2 this month, and we've got over 400 people listening to them. So it's a small start, but we're quite pleased with that progress.
Okay, it says on your report that although we had a lot of positive stuff, there was also negative stuff about car parking.
Yes, I think
it was a national thing.
Yeah, it was national, not specific on us, but they pick up local trusts. So the only negative we had, if you like, during that period was specifically on car parking, but we did have a lot of positive news coverage locally.
Thank you, Chairman. So at the end of Q3, so the end of December, before the application of the Provide and Sustainability funding, the trust was 400,000 ahead of plan. So we posted a £29.9 million deficit, so a very large number, but that was ahead of the year-to-date plan we had agreed with our regulators. But when we applied the PSF, the Provide and Sustainability Fund, which is the second indicator on the page, because we haven't achieved the A&E targets for Q1 and 3, we were 400,000 behind plan. the cost improvement program, which is the trust program to improve efficiency. At the end of Q3, we were £600,000 ahead of plan, so we were delivering ahead of plan, but the requirement gets harder in the last 3 months, as you can see from the red dotted line there. Our capital expenditure we've talked about at length, and Trevor and his team continue to be on target to deliver, and by the end of this year we will have spent just over £49 million on a combination of estates predominantly, but medical equipment and IT investment as well, which the trust think is very important enablers. Cash is a very key indicator for us, as I've mentioned previously, and we're holding £14 million more cash than we're planning to, but we have reasons for that, and we will hold the required amount by the end of the financial year. And lastly, as an indicator of cash management, we've paid 94% of our suppliers within 30 days of the invoice date, and again, that's a very key indicator for us as well.
Thank you, Richard. Anything to add?
Yeah, I think all I'd add is that Rakesh, but also right across the entire executive team, are very heavily involved and engaged at the moment in terms of planning and budgeting for next year. It's a process which has a lot of engagement also with NHSI. So in terms of kind of reassurance, an enormous amount of work is going into the plans for next year, and how that ties in with the ask, if you like, from NHSI.
Thanks. Right, so that's the end of the IPR. So Peter, the risk register.
So the risk register, there's a few changes to it. So at the last Performance and Assurance Risk Committee, we went through section by section all of the adjustments that have been made. So there are no new risks identified. However, what we have done is the little red boxes as pop-outs that show the particular areas of focus, for example, around some of the staffing challenges, or indeed the one that's green around finances, is as showing some progress on specific measures. So the ones I wanted to highlight in particular were the change that we made, which is in a risk score for the nursing staffing shortages that went from a 16 to a 20 to reflect the particular focus we have and concerns around both the establishment levels and our ability to fill those shifts. So those were the kind of the key components of the risk register changes.
So, I mean, the overall feeling of the part committee is that is the key change. I mean, it's obviously quite a number of red boxes on here, but
yeah. So really that's the most material change is that particular score. But what we did do was really we went through the 4 sections. So we've said since we've been doing this in this way, our 4 key challenges around staffing, variability of care, our estates and infrastructure, and our long-term financial sustainability. And we confirmed that that's exactly how it still feels, and that those are many long-term risks with lots of short-term mitigations in place to continue to ensure that we can do the best we can and meet the needs of our patients as safely as we can. But those are long-run solutions required.
Right. So can you move on to the board assurance framework?
So I'll make just a brief start in terms of, so this is the quarterly review. So this is the Q3 review against the 6 key priorities that the board set itself at the start of last year's planning cycle. In summary terms, that we have made progress against a number of metrics and remain on track for some, but reflecting that these were particularly challenging priorities. So in the jargon, you're meant to set yourself SMART objectives, which may be sort of challenging but realistic, including that. So some of the indicators have changed from sort of some positive progress, but overall it reflects that there's still a lot of work to do. Rather than me sort of summarise all of those, but in headline terms, we've got some progress to make in Q4, so we would hope to see some modest improvement, but we won't be kind of, you know, green in all domains by the time we get to the end of the year because of the challenges that we continue to face. But if I don't know if exec colleagues would like to highlight any particular areas in here. The one bit which is sort of perhaps more of a technical point. So how do you get one of the risks? Sort of the scoring shows we've got 10.5 in one bucket. How can you have 10.5? Well, what it shows is that in one particular objective, one element, this is around the renal dialysis units. In one, we're pretty much close to delivering the St Helier site here, but the Croydon one will now not be delivered in year. So we kind of scored that as a half, you know, half green, half red.
Right. Okay. Any other exec or non-exec comments on the bath? Right. Thank you. I think it's really useful. It's very visual, which is very helpful. Right. I'm going to take all the committee papers as read. We've discussed all of that. So we're now going to move. Oh, sorry. Yes.
Could I just make one comment on the audit committee paper that's on here? You will see, if you look at the audit committee paper, that it said that we had an updated audit committee from the counter-fraud team. And within the NHS, there is a zero tolerance of fraud. And very unfortunately, several years ago, the Trust did suffer a fraud when some members of staff abused their position. And we have been proceeding this through the courts. It's a criminal matter, and these things take a very, very long time. At least one individual is now serving a custodial sentence because of that. And because they were found guilty in the criminal courts, we have been able to pursue them for the recovery of the money that we have lost. And I wanted to just share some very good news, which is that we have received more than £90,000 back through that. And I think it's a very, very important message that we send out to everybody, that we do take this very seriously, and that if people commit a fraud, there is no such thing as a small fraud. It is all going to be pursued.
Thank you. Thank you very much, Elizabeth. That's a positive update. Thank you. Good. Right, I'd now like to ask Sandy if he'd like to come and tell us all about...
We could go and be Dan. Save everyone.
Yeah, go and be Dan. Yeah, you might as well be. Today, as he's here. So, Guardian of Safe Working. Where is he? Oh, there.
Well, good morning, everybody. Interesting times. 2 years ago, we started reporting exception reports. Thanks to a massive effort of recruiting medical staff, we're now at the state where we have 320 trainees established and 306 of those posts are filled. Trainees are all encouraged to exception report. Now, exception reporting, we've had the conversation earlier about the hip fracture unit. It happens for many reasons. The most common are that you've worked extra hours and under the contract you're allowed to be paid if you exception report. So the very busy ward has a lot of extra hours going on and the people want to be paid for doing such wonderful work. Much more concerning to me and in terms of patient safety is the immediate safety concerns that the doctors are also allowed to report. And it's interesting that the areas that have many reports for hours don't have many exception reports for immediate safety concerns, which concerns me that there are areas in this hospital and at Epsom that don't report because it's felt somehow not to be the thing to do. So to overcome that, we've got a second route of getting information out where we have a ESTH Guardian Safe Working email that's open at all times that people can just send messages into, and that also allows the locally employed doctors who currently can't exception report because they're on a different contract to report things when they're working on the same rotas as the doctors who are allowed to exception report. So there's the downside. sort of summary of numbers. This time last year, the 3 months, November to January, 141 exception reports, 11 of which were immediate safety concerns. Same period this year, 43 exception reports, 6 of those were immediate safety concerns, but again it's this issue of they're not coming from the areas of high reporting. To try and overcome this, very fortunate in having Sam here, our new Chief Registrar, and he acts as the chair of the Junior Doctors Forum and is very much a connector between the junior doctors and the execs. That's it, really.
Thanks very much, Sandy. I mean, clearly it's welcome that the numbers have gone down from 140 odd to 41.
Yeah.
That's really good. In the areas where you say that people aren't reporting, can you dig a little deeper into the reasons why? Is it people? Is it process? Is it? I mean, what do you think?
My thoughts are, and Sam would probably be the better person to answer this question as he's actually at the coalface, is that it's just the tradition of the NHS. You're letting your bosses down if you report. But actually, they don't really understand the new contract. And I think a lot of them don't really understand why they're exception reporting. The contract is so totally different to anything we had before that it's hard for them to realise that actually an exception report on an individual basis is for money or time back. That's obvious. If you've got some sort of safety concern, you should report it, and there's a system there, closed circuit. They all have educational supervisors who they're supposed to interact with, and it would appear that some of that mightn't be happening as well as it could either. But that's more for Richard Bogle, the Director of Medical Education, to answer. James.
Sandy, I wonder if you can just give us a little bit of broader context. So from where I'm sitting, I'd be very concerned if we were at one end of a spectrum of either having far fewer exception reports than most organisations, because that might suggest something about our culture that would be stifling genuine either expression about safety concerns or excessive hours, because inevitably the nature of delivering acute medicine means that the workload is variable. Or if we were at the other end where we were getting a particularly high number of reports, that would also concern me, but for a different reason. I just wonder if you could give us some context about where you think we are in terms of our local peers. I know you sit on a broader London committee, so you have broader insight.
Broader London committee, and also now on the National Committee of Guardians. And for the size of our hospital with 2 sites, we're right plumb in the middle where we should be. That's nice. There are hospitals with over 1,000 trainees who've got 50 exception reports in 2 years. I would be concerned. Similarly, there are other hospitals that have got, we've got 600 total reports, so that's less than 1 a day for the reporting period. There are other hospitals that are well over 3,000 reports now with similar number of doctors to us. And it's almost as if they're being definitely encouraged to report everything, so that fines are raised. We haven't raised any fines since the first year. And those fines are used as leverage to get more finance to those particular departments.
I think one of the drivers, apart from the change in culture and the increasing awareness of educational supervisors and trainees about the utilisation of this system, which I very much value because it's another route into patient safety. But the driver for the improvement is our medical vacancy factor has reduced from 91 in April to 38 from where we are now. And so from a helicopter perspective, that is very good, but there are clearly some pockets where we have some concern, and I think that filters up possibly to you, Sam, and Sandy. And the areas that are on my radar are paediatrics and the emergency department, and to a lesser degree, medicine at Epsom. I'd just welcome your comments.
I probably agree with medicine at Epsom, especially gastro would be an issue. There will be stuff coming out of there, I'm sure. They don't report, but Sam and I actually had a meeting with some of their registrars, and they were saying that it's not a nice place to work because the workload's just so incredibly high. and that's what it is. The opposite of that is that at the Junior Doctor Forum this week, one of the registrars who's been in post over a year says the difference here at St Helier now for him is that he's not asked to do extra shifts. It's just much easier, the work's better, he feels better supported. So that would back up what you just said, James, that more doctors makes life easier.
Thank you. Sam, do you want to say anything? I mean, from the perspective of the front line, it would be really useful if you did.
So in terms of feedback from the Junior Doctor Committee, I think that the trainees, especially at St Helier's, are very grateful for the change. They are aware there's still more work to do. We've worked quite closely with estates and facilities to get a number of things put in place to help support junior doctors from a mess side of things, which has been appreciated. And I think that there are still some concerns, especially in the Epsom hospital, about things that probably need to be done. I think there is a reluctance for certain trainees to engage with the exception reporting system. The foundation doctors have come from a culture where this has always been normal, so do tend to engage, whereas it's the SHO and registrar level which will be more sort of suffering in silence, or are hear things and will kind of feedback. We do need the evidence to take things forward, but I think there's a bit of a reluctance because of the system not being something that they have had throughout their training, so I think that's an area that really needs to be looked into more.
Thank you. In terms of the mess and you know, hot food in the middle of the night, how do we stand now to where we were a year or so ago? Have we improved it?
So in terms of things, actually, that there's no longer reported to be any issue at all. There's been no concerns about access to food at all with the mess. It was more due to kind of related to the actual facilities. I think that there is more to do at Epsom. St Helier's has come on in leaps and bounds, and there's work in terms of disabled access to the mess, which is underway, which is very positive. And hopefully once that's in place, actually, there might be improvements in handover that can be used by using the senior doctor mess room and there for that. At Epsom, I think there's a lot of work that needs to be done regarding the space and looking at out of hours and provision, but we've got a meeting arranged for next week, and I think there's going to be more work that we need to be doing.
Thank you. Trevor, do you have anything on that?
I think just a lot of the issue around Epsom is where we have moved the Met facilities, and there's a disconnect between where there's rest facilities and sleeping facilities, and we're acutely aware of that, and we know that it's been going on for some time, and we've got to resolve this. So we're focusing on resolve that. There's a meeting next week with key people to try and resolve those issues.
Thank you. Martin?
Yeah, thanks. Welcome the huge improvement in terms of the number of doctors. I guess on this issue, kind of from a non-exec perspective, for me at least, there's always this question about how much are we hearing what people really think and feel, because that's fundamental to managing the risks. And if you compare it certainly to other experiences that I've got, that if you take other high risk areas like pilots in airlines or oil exploration, there's a lot of systems in place that also mean that as well as all the things we're doing, there are anonymous or identity protected channels as well. And it may well be that we have that, I'm not aware of it. But so it's really two questions. How comfortable are you that we are hearing what people really think and feel? And are there ways that they can raise issues anonymously?
The only way they could raise an issue anonymously is by sending an email not from them, as far as I can see. But the big advantage we have now is having Sam in post, who can actually go and talk to them as one of them. And they know that his role is not as an exec, his role is as to lead the junior doctors. Because for those of you who don't know what Sam does, you tell them.
So as the chief registrar, I work clinically as a palliative care registrar, but I also have time set aside involved with quality improvement and supporting junior doctors. So I do go to some of these meetings to get an idea of what happens in a trust sort of setting. I share relevant information with juniors, and they also will try and spend time going from ward to ward. I'm mainly at St Helier's, so Epsom I'm only there clinically one day, so I don't actually engage as much with the Epsom doctors, which is a shame just because of how my job is set out. But at St Helier's I will spend time to go ward to talk to people to get an idea of what their concerns are, what their issues are, and then from that I'm working on a number of projects to try and improve things related to issues. So there's going to be a big stream related to trying to improve induction that's going to be underway mainly through PGMC, because that's been an area that doctors have found frustrating and difficult. I'm working on a project to look at referral processes and sort of collate the information of how to do referrals. I've identified a gap where certain referral bleeps wouldn't be held if a registrar was on nights or on leave, and we're actually making sure that we're making things safer so that actually if someone is off, there's a way of that referral going through rather than not being answered. So there's a lot of things that we're trying to do to improve things. In terms of another area, thinking about reluctance perhaps to speak, again, most people will share things with me, which is good. In case they don't because of my role, I'm thinking of doing a sort of junior doctor survey through sort of SurveyMonkey. I've done this before with palliative care trainees, and it is anonymous. I won't be able to see the results unless I particularly will click through to see that, but I wouldn't be doing it. And it would be able to generate kind of a free text response about different issues to get hopefully a better global idea about where things are at.
That's excellent, thanks.
And Martin, just to add from a medical director perspective, that we infrequently, but we are the recipient sometimes of feedback that is anonymous, and which will prompt an investigation from our perspective into the issues that are raised. We seek to triangulate the information, but I think it's important to acknowledge there are many different routes that the junior doctors may use to share concerns.
And just one other thing, I think the junior doctor voice is incredibly important because they are in a unique position, having rotated between different organisations on a frequent basis. So they see what works well and works badly in different organisations. And within our organisation, as many of them rotate from specialty to specialty every 4 months. So harbouring any dissatisfaction is actually a very useful way to channel it into a positive voice for change. And the other route for anonymous feedback is the annual GMC training survey, which will be opening probably in the next few weeks. And we have a very good response rate. I think the junior doctors see that as quite a powerful tool. And part of it talks about their experience, but there's also a section on their perspective on safety, patient safety and experience. And we often get a lot of very useful feedback through that route too, and that's anonymised.
So you suggested that there are pockets of good practice and pockets of not so good practice. So the example there was the gastro Epsom perhaps, and I think a pocket that we saw today was probably in A3 in the orthogeriatric. Is that a good word to use? If someone were to raise their hand, say in the gastro, what do we actually do about it? What do we actually do?
So in terms of things, it will depend a bit about what the situation is, but it may be that either, if it's related to staffing and workforce, for example, we had a meeting with workforce rota coordinators, Sandy and myself, to try and discuss what the issues were, and then we will try and work out how to move forward from there. I think part of the problem in this area in specific was we needed to have some kind of information from them to take things forward further, and I think that a number of points were identified, but they needed to kind of go through the system for us to be able to show that, and I think that's where that fell down, was that we'd had a good meeting and action points, and I think then there was either through reluctance or other commitments, difficulty with them then coming back to us with sort of a written plan as to what they needed us to be able to do to make things better.
So reluctance from the junior doctors or reluctance from the other bits of the workforce?
No reluctance from the junior doctors to outline what the problem is.
So they come with a problem, you tell them here's an action,
yeah,
and they
just So what I do then is I raise it with the clinical directors and the medical directors, and of course the Director of Medical Education, because it's sort of partly in his take as well. In fact, mostly in his take.
I mean, we can take this offline, but I mean, I think that there's something in that in terms of what do we do, how do we take this forward. Okay.
Right. Thanks, Sam. Thanks, Sandy. Very useful. And we'll get your next update. What, in 6 months? 3 months. Okay, that's great. Thanks very much. So move on to Ruth. Excuse me, with the 7-day service update report.
So if I, thank you, Lawrence, if I just explain what this report is and why it's important that it's here. You may be aware that in 2013 the NHS laid down 10 standards for delivery of 7-day services, with 4 of those 10 standards being what were called core standards. The expectation being that by 2020 all acute trusts would be compliant with the 4 core standards or to deliver 7-day working. The 4 core standards are time to first consultant review, so making sure patients are seen within 14 hours of acute admission by a consultant, patients having 7-day access to key diagnostics, key 7-day access to consultant-delivered interventions, such as a radiological procedure. And the 4th of those core standards is making sure that once patients are admitted, they have daily or twice daily review by a consultant, if that is deemed to be appropriate for their care needs. So they are the 4 core standards. And you may remember that historically, the system has been that each trust had to participate in an audit of their compliance against those standards on a twice-yearly basis, and we've brought those audit findings here previously. In the autumn of last year, NHSI and NHSE decided that a more reasonable way of looking to benchmark trust compliance against those standards was not to mandate a large-scale audit which was then collated nationally, but to ask trusts to self-assess their compliance against those standards using a stipulated framework which they've given us in the form of a BAF, essentially. So there has not been a national audit or against the 7-day standard compliance since May. There would ordinarily have been one in the autumn. That was put on hold. And instead, what all trusts were asked to do was to take the findings from the audit that took place in May 2018, put it into the self-assessment format, and ensure that there was sight of that BAF through the public boards during Q4 of 2018-19, which is where we are now. So I want to caveat this paper by saying that the data presented here is not new data. It's data that's obtained from the audit in the spring. But the importance of this being here is so the board has oversight of the new format which we have been mandated to use to self-assess ourselves with on a 6-monthly basis. So I hope that context makes some sense. If we then actually go on to look at the content, if you like, which, as I say, has been mandated, so it's not a format that we have developed, it's one that's been used nationally. I think it's important that we remind ourselves of the findings of that audit that took place in May and highlight the areas where there is further work for us to progress. We have done very well through changes to job plans, changes in ways of working, changes in putting together ways of recording consultant review, in ensuring that our patients admitted as emergencies are seen within 14 hours by a consultant. And the last audit we undertook found that we were compliant with that standard over 90% of the time for both weekends and weekdays, and that is, and we are a positive outlier in that respect. However, it's important that we actually maintain momentum and ensure that clinicians remain focused on that timely review. We've heard a lot this morning about the surgical ambulatory care unit. Actually, one of the real positives of that unit being in place is that the work pattern of the surgeons has changed, so that there is more now consultant presence on the surgical services and also in trauma and orthopaedics. So whilst we've met the standard before, we must not be complacent. And actually what we found key to delivery of that standard is making sure there's a very clear template for recording consultant review in the notes, so it's captured on a real-time basis. So more work to maintain that standard. In terms of access to diagnostics and consultant-delivered interventions, largely through working across a network, we are compliant. However, I just want to highlight that in terms of access at weekends to echocardiography, this is an area in which we are challenged, and most district hospital sites are challenged, and where there is real potential to work across a network so that that service can be provided across a sector, rather than setting up a service for a very small patient need on each of the 4 acute sites we have in southwest London. And then I think the most important thing that I really want to highlight, and the standard that will need most focus for us, is Clinical Standard 8. That standard mandates that if a patient is in a high dependency unit, they need twice daily consultant reviews. And largely that standard is met, which is very positive. However, the challenge for us when this audit was done in May, and the challenge that we face on an ongoing basis, is ensuring that all patients that will benefit from a consultant review on a daily basis have that daily review, particularly at weekends. And you will see that's the standard that we were not able to meet. Clearly, we are working with our clinicians through job planning to see how much we can increase the consultant hours available to undertake patient review at weekends. But in some specialties, particularly in our medical specialties, that is a very challenging standard to meet with the currently available workforce.
Ruth, can I just ask, when you say, I mean, it looks very sort of binary at the moment, you either meet it or you don't meet it. How close are we? I mean, have we missed it by a vast margin, or are we nearly there and not met it?
For the consultant review at weekends, it's a not insignificant miss.
A big miss?
Yeah. And you know,
I mean, can you put any metrics on that?
I can get the metrics, but I don't have the metrics from the top of my head. So what is important to note is that you know, we do ensure that our sickest patients are seen by a consultant daily, but to have a consultant available to see every medical inpatient on our sites, that's where the challenge lies.
And is that a challenge that other trusts have?
Absolutely.
Is it an unreasonable standard?
Not at all, no, not at all.
So it's something that's got to be fixed by everyone?
Lawrence, we did discuss this in considerable detail at PSQ, as I'm sure if Pat were here, she would remind everybody. And as Ruth said, it is very much a moving feast at the moment, and something that we're satisfied the executive have got well under review. And what we are seeing here is, for want of a better expression, our baseline starting position that we're setting down here, and that, you know, it is very useful for focusing where attention needs to go in the future.
Okay,
but it is something that PSQ will be looking at regularly.
Chris, you're right. No, okay, Aruna.
So very quick. If, I mean, our doctor vacancies or consultant vacancies are pretty much. We've got pretty much the whole cohort. So I'm a little bit confused. If that is the case, then why are we not able to meet this? Is the establishment number?
Yes.
To meet this, we need to relook at the establishment.
Absolutely.
Okay.
Yeah.
Okay.
I think there's possibly also a changing pattern of work of the consultant workforce, because those of us that look after inpatients also deliver outpatient work or diagnostic work, and we have conflicting pressures on time, and there's a huge transformation program underway in terms of outpatients that has the objective of potentially freeing up time for consultants to be more available to look after inpatients. And I think most hospitals would recognise that traditionally, when looking at consultant job plans, the starting point has often been about delivering outpatient care, and ward care has been slightly Cinderella in comparison. and we're trying to refocus and rebalance the job plans to allow enough time for people to be on the wards. But we clearly need to relook at our establishment with this in mind.
Is this something we should take up at the board as well? Because we've got the nurse in this establishment review. Are you going to be doing a medical establishment of doctors?
So to be clear, to review the establishment of consultants
Yes.
would be a major cost pressure, new set of costs. If we have a single acute site, you can deliver this standard because you actually have the people in the right place. That is the biggest reason why this is a really very hard thing to do. And the priority that we have agreed for next year is to sort out the nursing establishments because we have identified really quite a big gap, right? So this is not the high priority thing for us to focus on for next year. It's a acknowledgement of we're missing this standard. We wouldn't say that this was the most important thing for us to prioritise for improving quality in Epsom and Helier for now.
What I'd like to add is that nationally it has been left open to trust to decide how they self-assess themselves. So if we chose to, we could say, we know that Dr. X is job planned to do a ward round at 8 o'clock on a Tuesday morning, therefore we know he will have seen all the patients on ward A3. We are not taking that approach. We will continue to do a notes audit because our previous work has shown that there are sometimes disconnects between what is in the job plan and the care actually delivered. We've relaunched a steering group to oversee this because I think the other part of what we need to do in terms of that daily review is actually to identify the patients that need a daily review. Because if you look at the language used here, it's not saying every single patient in a bed needs a daily review, it's every patient that is an acute patient. And so we are doing some work looking at the criteria we've laid out for a potential future model of care to ensure that it's the sickest patients that are prioritised to get a daily review. So I think it's important that we continue to progress this work, but we are not seeking to actually achieve a daily review of every patient in our hospital beds to be reviewed during the course of the next year. It's about making sure we utilise the senior resource we've got most appropriately.
Chris? So just, so if a patient's not getting a consultant review, do we have any confidence that they're getting a medical review?
Yes. Yeah, so I think that's important to note that yes, absolutely. And the notes audit actually gives us great assurance in that regard.
Good. Ruth, thanks very much. I think it's really important and a good discussion as well. So let's move on to the seal.
Okay, so this is for noting that the Trust has used the seal on a number of occasions. So the first one is for 5, 6 and 7 Birches Close. That's providing us with key worker accommodation in Mitcham. And that's just in terms of the lease for 5 years. It ends on 2020. It's taken some time to get the legal documents in place. The next one is around the life.
It ends next year.
Yes.
It's taken us 4 years to get that sorted.
So we've been working with our colleagues in NHS Property Services that have been quite some transient workforce and different restructures. So it's been a challenge in getting a formal setting in place. Yeah, we've been using it. We've been effectively using it for some time. So moving on to then, we've used the seal to grant the lease for the rental of the ground floor of Langley Wing and alteration with skin laser care clinics. They're currently in Rowan House, and as part of our rationalisation programme, they move into Langley Wing. And that's for a 10-year term, but we have a 5-year break on that we wish to use to help us out. And then the last two areas that we've used seal for is Dina UK and Mechanical Services Limited, and they're subcontractors to Breathe Energy, who are undertaking our energy efficiency replacement of the critical infrastructure for our boilers and plant on the St Helier site, and these are collateral warranties, so they're not of financial value. They're just to give us some added warranties and benefits going forward.
Thank you. Contracts over 50,000, Rakesh. Does anyone have any comments on those? They all seem straightforward. Good, thank you. Any other business from anyone? Good, thanks. Right, so that's the end of the meeting. We'll take questions now. We're a bit stuffed for time today, so it's probably for about 15 minutes. So, at the back, Nigel.
Thank you. Yes, this is a double one, really.
Can you either stand up or speak a little louder?
Yes, sorry.
Sorry, thanks.
It's a double one, really. One for, I guess, the Chief Executive, and one for Rakesh. And it revolves around, specifically, where we are with the sale of Epsom General Hospital land. Because obviously, I think it was some time ago when you stood up, Daniel, in front of everybody in the audience hall at Epsom when Chris Grayling was there, and you said unless it was sold by the end of March, it would have a very material adverse impact on the deficit, and various funding would not accrue. So, you know, and Rakesh has demonstrated already that he's lost, well, it's going to be difficult to meet the deficit as stipulated with the reduction plan for Q4. So all of this is coming together, and I'm just wondering where actually the trust is in the context of the financial situation. Thank you.
So we've got a few weeks till the end of March. We're on track to complete our land sale by the end of March. I think we said at the public briefing in January that we had done the piece of work that that we promised at that big meeting in Epsom, which was to confirm that if we did sell the land and that there was to be a new acute facility and it was at Epsom, we could fit it onto the site. Our commissioners did that piece of work, and we put that in the public domain to confirm that we could. And we're just at the final stages of our process where a lot of people did express an interest in purchasing the land, and we also gave a commitment that there would be an element of social care as part of the land sale, and I'm hoping that we will get to before the end of March and be able to tell everybody what has happened, but currently it is on track to deliver.
Thank you. But what about the deficit impact? I mean, it looks as though the deficit projected, notwithstanding the inflow of land revenues, which was part of the reduction of it, is going to be worse than you projected. Is that not right?
No, so we did agree with our regulators that we would host a deficit for this financial year.
Yes.
Oh, sorry, I thought I turned it on. So we did agree with our regulators this time last year that we would post a deficit at the end of this financial year. And at the end of Q3, notwithstanding the land, and I think, as Daniel says, we're on track to deliver that land sales. We're at the end of Q3, we're at 400,000 ahead of that, and so we'll see what the next 3 months look like. But so we are on track at the end of Q3.
So you're positive that the number you gave is going to be roughly about right?
Well, what we've posted so far, yes, and I'm in the process now that we're doing a detailed forecast, and that will give me greater confidence to say where we will land.
Thanks very much indeed.
Okay, thank you. So Sandra?
Couple of things really. Can you tell me why the availability of lifts affects the numbers using the birth centre? Oh, thank you. That's my first question. Can anyone tell me why lift availability affects the use of the birth centre?
My simple understanding is the birth centre is on a different level from maternity, and therefore if people wanted to go to the birth centre, it was actually quite difficult for them to get there without a lift. Is that correct?
But it won't be a difficulty for people to go to a different hospital altogether because you've closed one of the 2 maternity units. So a lift to a different floor is a serious impediment, but a different building in a different town, you don't expect to be an impediment.
So
is that what you're saying?
The impediment is mostly around access in an emergency to theatres and whatever.
Exactly. But
I don't
because you're planning to move the maternity unit further away from most people in an emergency. So one floor makes a difference, but a different town doesn't in your plans.
Let's just be, you're conflating 2 completely different things.
Am I?
Yes. So the issue between the birth centre and the delivery suite is that if the ladies who go to the birth centre are deemed to be the ladies who have normal births, and it's all going to be simple.
Yep.
The reason why you want them co-located with inpatient consultant-led delivery suite is that sometimes it goes wrong.
Indeed.
And in an emergency.
Yeah.
And at Epsom, they're on different floors. And if there's only one lift in the Epsom building, and when it's not working, you cause a risk, because if something went wrong in the birth centre, we would find it very hard to get the lady to the delivery suite.
Yep.
Right? So that's why the birth centre numbers went down. It is an entirely separate argument as to what is the configuration of maternity services for Epsom St Helier for the future, which we've had loads of conversations about, and we can have the conversation again, but we don't agree,
I'm just confused that you think the difference between one floor and another in an emergency is significant, but one town and another in an emergency, maternity emergency, is not significant. But thank you for your answer. The other thing I wanted to ask you about is how do you feel about yourself and the nation missing A&E targets to the worst degree than you ever have before? Is this a good time to close another A&E when you are already failing to hit your targets by a record level?
The short answer to that is, if you look at what is the cause of us and Epsom and St Helier not to be able to deliver the A&E standard, it is down to one thing now, which is not having enough A&E clinical staff. And we are absolutely sure that if we could have our A&E clinical staff in one place rather than two, we would do much, much better at treating patients in A&E more quickly, and we'd also be able to do it to a higher standard of care. And the best example of that is at night, where we have minimum staffing levels at both Epsom and St Helier, which is one consultant who's on call and one middle grade on each site present. And if you could have the two middle grades together in one place, we would be able to treat many more people more easily, because currently you have peaks and troughs of demand, and you have on one side the doctor being overwhelmed, and on the other side they're not having enough to do, but you can't put them in one place, because if you took the middle grade away from the site that didn't have so much activity, you wouldn't actually be able to run an A&E. So everything else that is in the emergency care pathway, we have done really, really well at in Epsom and St Helier. So we have not had patients waiting for beds. We have not had people queuing in corridors. The partnership.
You have had 4 black alerts, which you didn't mention in your review, but it's in the paperwork.
Yeah, but that's all about the capacity in the A&E department, most and nearly all because we haven't got sufficient A&E staffing. So I think that the case for us in getting to a single acute site is actually strengthened by what is the current cause of the operational problems.
So you don't think the operational problems are caused by the number of A&Es that have already been closed in this country?
Well, not in the catchment of Epsom and St Helier, no.
No, but that's to come, obviously, by your plans. Oh, one last thing. At the last meeting, I asked about your plans to sell the land, the renal land at the back of the hospital. And you categorically denied that you had any plans to do that. And I knew that I had it in writing that that was your plan. I've since found it. And you denied planning to sell the land for the renal unit. In your refresh document, and I quote, you say, when the renal facility has been re-provided, we would like to demolish those buildings. This will enable us to sell surplus land for high-density housing. This land, which you say you're not planning to sell, this land sale could be scheduled for 2019-2020. Could you retract your assertion to me last time we met that you definitely have no plans to sell that land?
So Sandra, I think you're referring to, again, the consultant report. I haven't actually seen that paper, so I assume it's that. But I think it's very clear that the Trust Board has a state strategy, 2016 to 2021, and one of the views that we've looked at is moving desperately needed inpatient, renal inpatient wards from the poor conditions they are,
Yeah.
and put them closer to the new facilities. We're then suggesting as an option that we could demolish those buildings and we could relocate some of our car parking and look at the car parking area as a future potential land disposal. But I think it's really important to say that we aren't in any position to do that at the present time.
You put it in your refresh document. I'll show you if you like. It's in there. You want to sell it, and not for a car park. You want to sell it for high density
Sandra,
housing.
I think the document you're referring to is a document that I produced. I'm very clear. We are not looking at selling the renal land.
Why did you say so then?
So I can't see that from here, but I think you'll find it's about relocating the car parking facilities.
Nothing about car parking.
Just to speak.
So Sandra, this is what you're showing me here is relating to Epsom. That's Epsom Hospital.
No, that's referring to the page before. This page is talking about St Helier. It very clearly said Helier renal unit, selling it for high density housing this year or next year. Quite clear. It's nothing to do with Epsom. That's something referred to in a previous paragraph.
So this is referring to that we'd demolish the renal facilities, and therefore would potentially, if we move the car parking, we'd have the car parking for potential land sale.
It doesn't say anything about car parking. It talks about selling the renal land for housing.
It's summarising our 2-year operational plan that we're at the end of.
Are you going to take it back?
Thanks, Don.
Can you take that back?
Sorry?
You denied that it was happening. Can you retract that?
So we are not going to be selling land at St Helier in the year 1920.
Why did you say you were then?
So we have an estates plan that we're trying to work through that's going to take years and years to do.
2019 it says.
Yes. So when we wrote that, we thought it might be possible to have re-provided all of the renal wards in the main building, but we haven't yet.
But you're going to do that, but you're talking about selling the land this year or next.
So this year and next, we will not be selling the land.
So you retract this statement now. Can you put that in writing? Because it's in writing that you plan to sell it.
Could I just point out that we've also undertaken a review as part of the Improving Healthcare Together, and we're also quite clear that the renal unit land and other things might be required if St Helier is chosen as the primary location. So we've also had to review our plans in light of we need to make sure that we are not prejudging any of the outcomes or the primary options for.
This is a new document.
So that's not a new document. That refers to an operating plan that I think was submitted last year.
Yeah.
Right, I'm going to move this on. Bob.
So I think I've got 3 things that I would like to say. I don't need this, do I? So Epsom, how does it go, Chris?
That's fine.
Okay, so Epsom Comet had this article on the 31st of January stating in the headline, EMEF booted out, right? And the majority of that was to do with, it was to do with Bess, and she's gone, right? So, no, I know where she is. I haven't seen her, but hi, Bess. So, and in the same paper, I forget whether it was page 14 or page 18, there was Walk for Wards article, and then you've spoken about it this morning, Daniel. Now, what I would like to understand, and I've had a look on the net about the NHS, your charity, right? And your charity says that the trustees for your charity, a trustee for your charity is ESTH, right? Now, if money is, and this is for the nurses as well that I'm talking, people around the hospital that are getting money in your walk, where is that money going to go? Is it going to go into the general fund of your trust, or is it going to go into ward places? And
one is, we've been really clear that we want as many departments as possible in Epsom and St Helier to be able to raise money for themselves, and then we're providing a vehicle in which they can do that through doing this walk. And for every £1 that they raise, the hospital is going to put £1 in as well. So a great example is Gloucester Ward at Epsom have just done a walk themselves, and they raised £6,500. So now they've got £13,000 in which to spend on. They wanted to raise money for respiratory equipment on their ward.
Okay, located where though, Daniel? Located where?
So in the Gloucester Ward pot of the charity. So we have this big charity called Epsom and Helier charity, and it's got lots and lots of different lines in it for all the different places.
145. Six, I think.
And so one of them is Gloucester Ward. But a big difference, not wanting to be too personal about this, is 100% of the money raised will go to the area where it is raised for in this charity, and that is not the same for the Epsom Medical Equipment Fund.
So you have to come up with some figures then, don't you? Why is that? Why is that not the same?
Because we're not. So what I think what many people who have donated to the EMF have not realised is that they're also paying money to pay for BESS from the money they're raising, and they don't realise.
So how much are they paying for BESS?
Well, go and read the accounts from the Epsom Medical Equipment Fund, and also they haven't realised that the money they are raising is not for a donation to Epsom Hospital. The things that the money is raised for, they are loaned to Epsom Hospital, so that the charity ends up with a massive balance sheet of over £1 million worth of assets. And we have not managed to agree with with the Epsom Medical Equipment Fund a way of working that enables the money being raised to actually be given to the hospital. So we haven't accepted any equipment from the Epsom Medical Equipment Fund for quite a long time now.
We know, don't we? Yeah, I know.
So there you go.
Okay, but somehow...
Bob, the walk, it's a new thing. We've not done it before. We've re-energised our corporate fundraising and our trust. And the walk is the first big hospital-wide event, and we are getting great support from all the wards, all the departments of the hospital. Lots and lots of people have signed up. Lisa will. Listen, would you like to give a quick update as to where we've gone on this?
Can we call it quits there? I understand.
It might be useful for everyone to understand about it and where we've got to.
Yeah. So all of our wards and, to be fair, our corporate areas as well are really interested in helping to raise money for specific projects. So a lot of the corporate areas have buddied up with wards to raise money for their favourite ward. And what we wanted to do, and it actually came from staff, part of the Your Voice, Your Values, people said that they would like to do something collectively together, and they cited a lot around either a picnic in the park, or a lot of people came up with either racing between the hospital sites. They wanted something, a vehicle, as the chairman said, to actually come together to be able to do this. People are voting online, so a lot of people who don't want to walk but want to get involved are doing marshalling, because we need marshals. We've got a huge amount of people from Trevor's team particularly who have done this kind of thing before, who are helping to organise it. We've got the union from the trust's point of view involved as well, and they are, so particularly the nurses teams are actively involved in helping to organise it. So it is a mammoth piece of work to do. It's all being done in-house, and we're actively promoting it, and we've got hundreds at the moment of people who've already signed up in one shape or another, even those that don't actually feel that they can do the walk between the hospital sites. We've got, there must have been about 20 people now who've trialled it to make sure that we can do it, because it's quite a fun walk to do, so there's quite a lot of people that have already had a go at it. And as you say, Gloucester Wards have already beaten us to it because they're out there and about, and they've wanted to get ahead of the game and get their money in, so it's a big activity for us. It's been well received.
Very much.
Okay,
right,
so
I've only got,
thank you very much.
Thanks, Bob.
But
we are running out of time fast.
Okay. Daniel,
hang on a minute, mate.
You did not say we have employed 2 people, or you've got a team now that you're paying for. You're paying probably 100,000 a year for this team, yeah? And you have to consider that as well. That's not, yeah? That's
no,
not fair.
Bob, we made a decision that we would professionalise our fundraising, just like, I mean, you've no doubt seen the Marsden, what they do, George's, Kingston, all the hospital trusts around here have got a professional fundraising operation. We are basically catching up with that. So that's where we're at. I'm just going to move on now because we've only got another 5 minutes.
I'm not finished.
Yeah, but time is against.
I'm sorry, you dealt with a lot
other
of things.
people an opportunity.
I've come here, I will not come back, right?
Oh, you will.
This is your last time.
You said that last time. You said that last time.
Number one, no, sorry, before lifts, I'm going to say sepsis, right?
Right.
We were promised a report. Has that report come out on sepsis?
So I'll have to go back, Bob, and look at what commitment we made in terms of reports. But what I can say quite definitively is that the focus on sepsis is extremely high, and we've got some increasingly positive outcomes in terms of our sepsis data. We were reviewing this yesterday with stakeholders, and in Q3 of this year, we've now got 98% of patients coming into A&E with possible sepsis getting their IV antibiotics in an hour. So some really positive progress on sepsis. We are appointing a clinical sepsis lead. We've refreshed our sepsis policies. So what I can say ahead of any written document coming here is that from a clinical perspective, there was a lot of very positive work and outcomes to report in terms of our management of sepsis.
Okay, thank you. And
thanks.
Lifts. This might be really useful for you. I have a sort of a comparison for you. I have a friend who was in business for himself. He was a guy that his skill was sewing machines, and he went broke, and he went to work for a company that used sewing machines, and it doesn't matter who the company was. They wanted these sewing machines going a lot faster. They wanted them operating much better. And because this chap's whole business, whole life had been sewing machines, and he was really proud of what he did, he turned this company around the use of these machines, where they'd gone in and been serviced and come back again, by being very careful, by being super careful. Yeah, you can get a lot more life out of the thing. Now, compare that with your lifts. I don't know how the stuff is serviced, I don't know how anything, but there has to be some sort of, why are the lifts packing up? They are packing up for a reason, aren't they? And we've heard about it, but I'm just saying, perhaps we're not going to be looking at the right thing, right?
I think Trevor just said that we are changing the way we do our maintenance.
I understand, but I've said something you don't want to hear.
No.
I give it up.
Okay, thanks very much. Right, we've got time for one last question. So I think it ought to be Bess, really, because she was...
I've got a question, but I want to answer that.
Yeah, sure.
I don't get expenses. The small amount of money I get pay for petrol and things in my house, like electricity. It's a very small amount. So I don't get expenses. Anything I need comes out of that small amount, like petrol and running the car. I own my car. I paid in full for my car. That my fund didn't. But the question I'd like to raise is, you have been given equipment or loaned it, and you've sold a lot off. Where is the money? You never consulted the fund, and we haven't received any money. That's one question, and I've sent you a list several times. But my question is, patient first. I don't believe it. Fancy putting outpatients in the back of the hospital. They were all in one building where they were close to X-ray, diagnostics, ultrasound, and pharmacy, and pathology. Now they're at the back. And what? A brand new lift breaks down. It's been in turmoil. The patients are so upset and stressed, and they're missing their appointments, they're having a go at the nurses, which I've asked people not to, because it's not the nurses' fault. They go home very, very stressed after a day. The signage, they tell me, is very bad. I know round the hospital, so I can't comment on that. But patient first, you're going to put management at the front of the hospital. Cars for outpatients could drive up to the entrance and drop them off. You've made it so difficult. They walk along the road where the ambulances go, which is dangerous, because if they come in with a blue light, they might not see that person till the last minute. Have you thought of that? No, you haven't thought of patient first. You've put them in a worse spot, and it's cost me and all the other ratepayers £2 million. What a waste.
Trevor, do you want to?
Yeah, fine. I think, first of all, if I pick up a couple of things in terms of the Epsom Medical Equipment Fund, I think I think the Trust continues to say this, and we do really much support and welcome the work that you're doing in the fundraising, and we continue to support that. So we do continue to support the car boot sales and the work with you around that. I'm sorry about the issue around equipment that is loaned by the Epsom Equipment Fund that seems to have either been sold or disposed of. I'm not sure you have given me that full list, but
I've sent it through an email.
Okay,
You
well,
keep losing documents. I mean,
so-
the last one you've lost.
So I think that's something we need to sit outside of this, but we have agreed the transition from loaning to donating, and that process that we're going through the legal documents, we need to address the outstanding matters and close that down in terms of that. So I think that's something that we need to work through.
You wanted me, the equipment that I raised money for, to go anywhere in the Surrey Downs area. People give me the money, I collect for a certain thing, like we're collecting for ultrasound equipment. And the money, as soon as we raise it, we've got it, we buy it. But the Trust have prevented us from getting it.
So Bess, let's try and go through those issues logically. So I think we are still working on a legal agreement between the Trust and Epsom Medical Equipment Fund of how we transfer from loan to donation equipment and resolving the issues of outstanding loan equipment gone missing or being sold. So that's the matter that we do need to resolve, and we need to spend some time on that. But equally, we know we've been quite busy. On the matter of the Woodcote wing, I think, and I'm really advocating that in the medium term, it's the right thing to co-locate all of our outpatients into Woodcote Wing, because at the moment it is a rabbit warren around Epsom Hospital trying to find 3 or 4 different located outpatients. Now, the work that we're doing in Woodcote, we've created the first floor, and we have co-located 30 outpatient clinics into that facility. We are also in the next few months putting in a X-ray room in there, and in early next year we'll be putting some phlebotomy in there. So the 90% of the diagnostics and the activity the patients will all see in Woodcote. You may not have seen it yet, but we've just started work, and over the next few weeks you'll see that we're creating a new footpath, a dedicated footpath from the visitors' car park up the side of the tennis courts to Woodcote, and that will create a visitors that you're parking, you're going straight into one building, and for 95% of those patients, they'll be seeing in that building and then be able to go back to their car park without having to go through all the corridors of the main building. So, and just lastly, on the lift, I am very disappointed about the lift. Unfortunately, we purchased a new lift 18 months ago, and unfortunately, until we moved that larger number of people in there, we didn't realise that it had some significant defects. We are working with the manufacturers who installed it, who have installed it not in line with recommendations, to get that repaired quickly as possible. We are actually even talking at the moment about some legal redress and compensating the Trust for the impact it's had in terms of having to provide other outpatients and the challenges we've had. So I think I totally regret that. It's a real shame that we spent £2 million on a state-of-the-art, fantastic new outpatient facility, and we've had this problem with the lift. We have another lift coming on board as well in the next few weeks, and we have got to get the access to that building correct. And I believe in the next 4 to 6 weeks you'll find that all in place and will be a vast improvement.
But it
Right, thanks very
was
much.
all in Headley wing at one time,
Yeah.
close to everything. Now you're moving everything. Look at the money that's being wasted. X-ray's got to move. Phlebotomy, it's crazy.
Yeah, but we're going to move them into the outpatients department, which
It
makes
doesn't.
sense.
It doesn't
Right.
bode well for a single acute hospital if you can't get one new department sorted without catastrophe.
Right, that's the end of the meeting. Thanks ever so much for coming, and we'll see you next time.